This is a video of robotic stump cholecystectomy. A 62-year-old lady presented with recent history of recurrent acute pancreatitis. She had a history of open cholecystectomy in 1999. She developed CVD stone in 2009, for which she underwent ERCP, and for the same reason, 2010 also she did second ERCP. MRCP was suggested a remnant G with multiple stones with clear CVD. So my plan is to go ahead with this kind of port position, standard port position for robotic cholecystectomy. So after going inside, there are dense omental adhesions which were first adhesiolysis was done. So you can see a left hand fenestrated bipolar grasper and right hand monopolar hook was used, and there is a 5 mm assistant port, three robotic arms and one assistant port for laparoscopic instrument was used. So there was no gallbladder to retract. It was a subtotal cholecystectomy in 1999 which was done. So I am using that gauge piece made into a cigar shaped and using it for retraction. So you can see I'm using used ICG, but there is no visibility of gallbladder. For the dissection, you can see the duodenum is densely stuck with the liver bed. So I'm just trying to release of the duodenum and the omental adhesions, and once it is that is gradually I would able to see the gallbladder, the remnant gallbladder, the glimpse of remnant gallbladder can be seen, but it was stuck with the duodenum. So I'm just reflecting the duodenum of the gallbladder stump. So it is almost after half an hour 45 minutes dissection, after which I would able to identify the gallbladder stump. So this kind of post cholecystectomy cases are usually difficult, and on top of that she underwent 2 times ERCP, so that made life a little bit difficult for me. But somehow I could identify the gallbladder now, and then gradually dissecting the releasing the omental adhesion, the duodenal adhesion, and then gradually finding the way to identify the gallbladder. There is a small stump of gallbladder which was left, which was actually containing multiple stones, and maybe that is the source and the reason of recurrent acute pancreatitis. So you can see, and just there is dense adhesions now. The callot strangles is very frozen. So in redo cases usually we happen like this, but I'm trying to see whether with ICG I am able to identify the any of the gallbladder structure. Maybe some stones are stuck at the neck, so there are impacted stones at the neck sometimes will prevent entry of the ICG into the gallbladder, so that will hinder the vision even if you use ICG. So I'm just seeing the right hepatic artery which is coursing just medial to the gallbladder, and there is a cystic branch of the cystic artery. So that is just I'm trying to dissect the cystic artery. That was actually in the initial operation it was divided. This is the remnant stump of the cystic artery. So even I'm trying to dissect the cystic artery stump, safeguarding the right hepatic artery, and right hepatic artery is very close in relation with the gallbladder stump. So you can see I'm just after identification I just coagulated the cystic artery with the bipolar grasper and then dividing it with the hook. Now just trying to do a fundal dissection, I mean the retrograde dissection, so that I can mobilize the remnant gallbladder from the liver bed. So you can see using the using the articulating movement of the robotic arms, I am using it with the traction, counter traction, and the dissection. So these are the difficult cases where robotic surgery or the robotic arms become very handy. And then again I'm trying to identify whether the ICG is getting into the gallbladder. It's not. So I'm keeping on further dissection based on the anatomical findings that I'm getting, although the anatomy is distorted. Still based on my previous experience, I have done 4 or 5 cases of remnant cholecystectomy by laparoscopy, but this is the difficult of the lot, and robotic surgery really become handy in managing these cases. You can see just using monopolar energy, a little bit of application of energy, I'm just trying to mobilize the remnant gallbladder of the liver bed nicely. And the visualization, the 3D magnification, and this is a video that you are seeing in 2D, but what I was seeing in the monitor and the console is the 3D vision that is actually helping me to getting into the proper plane to identify the going up till the up till the base of the gallbladder. So I can feel that there are some stones which is actually impacted at the neck of the gallbladder stump. So, and you can see how much gallbladder was left behind. And then posterior dissection was gradually done to mobilize the complete gallbladder from the liver bed. So very gently I am pushing it. Very gently I'm pushing it, the pushing the all the additions and separating it, and trying to go as much as below possible. So you can see the medial, lateral and the posterior dissection was quite nicely done to reach the part where gallbladder stump is tapering, maybe the cystic maybe it is a junction with the cystic duct and CVD. But again, as the ERCP was done previously, I'm just not worried about the CBD. So I'm staying much away and above the Ruvia sulcus, and trying to dissect the gallbladder as much as possible, the remnant gallbladder as much as possible, or around the 360-degree dissection. So gradually I'm just trying to go as much as possible towards the end of the remnant of the gallbladder, and seems there is a pulsation on the posterior aspect of the gallbladder. Maybe there is another branch from the from the right hepatic artery which is supplying the posterior aspect, and that can be the posterior branch of the cystic artery. So I could appreciate the pulsation on under vision. So I'm just dissecting the posterior branches of the cystic artery from the which is coming from the right hepatic artery. So you can see the right hepatic artery was very close relation with the cystic duct, I mean the gallbladder remnant. So it is actually lying in between the CVD and the gallbladder remnant. So I have to be very careful so that I should not injure the right hepatic artery at any point of time. So just after division, I'm just separating the gallbladder further down, and I could feel there are stones which are impacted at that juncture. So I've decided to open up the gallbladder just a little bit away from the junction of the cystic duct and a CVD, and so using the hook and monopolar energy, I'm just opening up the gallbladder. I could see this is full of stones. The stump is full of stones, and there is no bile at all in the gallbladder stump. There was a little bit of bleeding from the divided margin of the cystic duct, the gallbladder remnant. So I could able to cauterize with bipolar cautery. So now what I'm doing is I just lifted the gallbladder liver retraction and then kept a suction inside. So this is my assistant surgeon who is putting the suction and trying to suck the stump of the gallbladder. And I could see there are stones inside the cystic duct. You can see the large stones which are actually impacted. I'm trying to take out stones one by one under vision. So here is another stone fragments which is coming out, and then the large stone which was impacted, and then suddenly a gush of bile came out. So this is the reason why there is no bile was entering into the gallbladder remnant, and I could not see any ICG enhancement of the gallbladder stump. So this is sometimes one of the limitation of using ICG even if you have robotic surgery, robotic console. So ICG, using of ICG, if there is impacted stone in the gallbladder, the ICG dye will not enter. And but if you are experienced enough in handling this kind of difficult cases based on the anatomical knowledge and experience, you can proceed further. So now you can see that is gallbladder that is divided, and free flow of bile can be seen coming through the divided system. So that free flow of bile confirms that there is no more stones in the cystic duct. So I've decided to suture the cystic duct. So I've taken a 3-0 V-lock suture inside, and then So what you can do is I have changed my instruments. The initial bipolar fenestrated grasper was on my left hand, so I have taken into my right hand, and then the left hand I have taken the hook which was used for retraction of the liver, and you can see my how my assistant surgeon is helping me with taking it, manipulating the needle. So he is holding the stump, and while I am giving the bite, he is just after that he is taking out the needle nicely. So in that way I have avoided using uh, needle holder, robotic needle holder. So actually the robotic, if I would have used the robotic needle holder, that will increase the cost of the surgery. So to prevent that, I have used the fenestrated grasper as a needle holder, and the assistant surgeon is as my left hand working port. So and this the hook which are actually the truly I'm holding in the left hand is used for the liver retraction. So gradually the cystic duct is stump is nicely sutured using the articulating movement of the robotic instrument. Even if in this difficult location, this narrow position, this narrow area, I could have finished the suturing nicely. So you can see, so starting from medial end to the, then went into the lateral end, and then coming back to the medial end again, and then finally once the suturing is done, there is no visible leak of the bile. So finally the specimen were taken out in a specimen bag along with the stones, and the drain was placed in the hepatorenal pouch, and then the patient had an uneventful recovery and discharged on POD 3.